So next up, we have Professor Rajiv Khanna, who's pretty well known to many of us, I would have thought, but just quickly is the co-director of Queensland Immunology Research Centre and at QMR Berghofer, and has a very long and prestigious career in translational research into novel T-based therapies. Just as I was listening to that great talk from Ben, I got a request from the QIMR team about a request for some CMV-specific T cells from a patient in Adelaide. So it's happening right now. This is the cutting edge. So thanks very much for coming along. Really nice to hear from you. And I just click on here. I think, yep, great. Thanks very much.
Yep. Thank you. Thanks, Adam, for the invitation. I'm going to sort of share with you our journey on taking this cell therapy sort of approach that we've been developing over the last, well, over 2 decades. And I thought in 20 minutes, hope I can cover some aspect of it. So this is my disclosures. And so we've been hearing multiple talks today. And as you can see, there's a list of viruses, not to underestimate the importance of fungal infection or bacterial infection, because of my interest is in viruses. So these are the common viruses that you often see in immunocompromised patients. And they are, often associated with both stem cell and solid organ transplants, and they lead to many end organ diseases. For many of these viruses, there are very limited or no pharmaceutical interventions available. In other cases where they are available, their prolonged use often leads to very long-term toxicity or even drug resistance, as we often see in CMV. And Brad has actually very elegantly highlighted the importance of the immune response to these viruses to control these infections in long term, because while we can give preemptive or prophylactic treatments to the drugs to these patients, unless these patients reconstitute their immunity, they often will relapse as soon as you withdraw those drugs. So it's very important that we develop new strategies, as Brad is trying to set up new strategies for actually identifying patients who are actually at high risk of relapsing or reactivating for many of these viral infections. So our solution has been to use adoptive T cell therapy, where the cell therapy is actually manufactured outside the body of the patient and then adoptively transferred into the patient. We can manufacture both patient-derived T cells or cell therapies and also allogeneic. And we have one of the largest cell therapy facility in RBWH campus, which is part of the QMR facility, and it's called QGen Cell Therapeutics. We have 13 clean rooms, and all the cell therapies are actually manufactured on site. And we can then ship it to the patients right around the country. And even we have shipped the cell therapies to US and Canada and Hong Kong and many other countries. So our journey in this space actually started almost like 20 plus years ago. I remember the day when Scott Bell, who was a lung transplant physician in the Prince Charles Hospital, he approached my mentor, Dennis Moss, and discussed with him a very unusual representation of this patient who was a lung transplant patient and who developed a EBV-associated post-transplant lymphoproliferative disease. We actually were the first to develop cell therapy for a solid organ transplant patient for EBV infection. Although that treatment had already been tried in stem cell transplant patients by the Baylor Group, but we were the first to transfer that sort of a thinking or approach to the solid organ transplant setting. And it is very important to appreciate why that was so difficult or why challenging was that, because when you're actually manufacturing cell therapy from a transplant patient, in this case, a lung transplant patient or a heart transplant patient, you have a very high risk of not just expanding the virus-specific immune cells, but also the what we call alloreactive T cells, which can actually go and attack your engrafted organ. The last thing you want to do is to put into a patient a cell population which, rather than curing the viral infection, it starts attacking the organ. So we actually developed a very modified, you can say, sophisticated process that we could remove or reduce the expansion of alloreactive T cell, but specifically expand virus-specific T cells. And that was very successful. And one of these cases is shown here, where a patient who actually had a heart transplant, and she remained pretty well and did quite well almost up to 3 years post-transplant. And she started showing this very unusual presentation, had these nodules appearing on the dorsal part of the body. And when they did the biopsy, it was EBV-driven B-cell lymphoma. And in that case, the patient was offered an option of going for a chemo as a CHOP. And she said, no, I don't want to take that. But she had heard that we had already treated another patient with autologous T cells. And to our surprise, we did grow the immune cells from this patient, and she showed a complete response to all these nodules disappeared within 6 to 8 months. So that was a very interesting journey for us. And just jumping all those 20 plus years. And I think what is exciting to see now is that along with these CAR T cells, as you might have seen those commercial names, Kymra and Yescarta, you see there's a new kid on the block. It's called EBV-LO, and it is a new T cell therapy which has been approved by EMA and will be soon approved by FDA for use in the transplant space. So this will be the first virus-specific T cell therapy which will be available for patients in the world. So it is quite exciting, having done sort of background work for that many years, and to see this product come into the market, which is really exciting to see that. We've actually been able to expand from EBV to other viral complication. In this case, as an example, we collaborated with Jeff Hill, who was at that time was the Royal Brisbane Hospital stem cell transplant unit. And we were actually able to manufacture, I put in inverted comma autologous, because in this case, the patient actually had a stem cell transplant and remained sort of a pretty much normal for almost a decade. And they started developing this clinical symptoms, CMV colitis. Unfortunately, there was no way we could reach out to the donor. So we had to actually go back to the patient and pull the cells out, which was very, very difficult. I can tell you, we had to do leukapheresis and literally get very small number of lymphocytes from this patient, and were able to expand the T cells. You could see that at the bottom, that the patient showed a complete resolution of this colitis and no evidence of CMV infection, as shown with the black arrows and the post-therapy. And so, over the years, we've done other patients, and very recently we published this clinical study in collaboration with multiple, one of our colleagues at the Prince Charles PA Hospital in the Royal Adelaide, where we were actually able to use autologous CMV-specific T cells to treat those patients who had developed drug-resistant CMV infection. These are all solid organ transplant patients. And to us, pleasant surprise, you can say that we found that actually there was a dogma in the literature that particularly those patients in heart and lung or these type of patients, if the virus is actively replicating, if you put the T cells into these patients, you might have a risk of these T cells, while removing the EBV or CMV infected cells may also have a side effect on that. And to our surprise, we didn't find any major side effect of the T cell therapy. And in fact, the 11 of the 13 patients showed a partial or a complete resolution of this drug-resistant CMV. So it was a good sort of outcome from this small study. But for us, one of the major challenge has always been is to how to monitor these patients. How do we know the T cells that you're giving to the patient is actually going to benefit out at the other end? And so we actually been doing this sort of a new sort of a blood test or blood monitoring sort of procedures. And in fact, actually, I was telling at the lunch break to Brad that the CMV quantiferon was developed in our lab, although he doesn't think it's worth using it, but but hopefully, somebody will find better use of that kit anyway. So you can see there's an example of one of these renal transplant patient who was from Scott Campbell's group at the PA hospital. You can see the red line is the viral load in this patient, and the down arrows are when we're infusing the T cells. As the T cells are getting infused, the viral load is dropping, going down and coming up. But coincident with that is this blue line and the black line is actually the reconstitution of CMV-specific immunity. Once you achieve that, the patient very rarely will rebound again with the infection. So it's very critical to have a stable, long-term, stable T cell immunity in these patients to monitor that. So once you do that, you actually achieve a better outcome for these patients. Wherever the patient lose their T cell immunity, you often see the virus will reappear, and then you have to go through another layer of further treatments. Now, to that point, most of the time, we have been manufacturing cells for one patient, one treatment, and then taking the patient into the clinic. And there are benefits of that. Yes, you're using an autologous product, but you actually are waiting for a patient almost up to 4 to 6 weeks before you can actually offer the cell therapy to the patient. And it's a cost, the time, and also it's actually during that 6-week period of time, most of the patients would have gone even worse what they were starting point when we originally took the blood. So we now actually moved more into what we call the allogeneic space. So what we do is we actually manufacture the cell therapies from healthy volunteers like you and I. And then we manufacture those cells, store it as a bank, and then offer to the patients. So I'll go through that, what we do. So there are two broad strategies that you can do. One is actually to manufacture these T cells from healthy volunteers, which are directed to single virus, that it could be CMV, EBV, or BK, or adenovirus. The other approach, which we are now currently using, is rather than doing individual approach, we actually manufacture multivirus T cells from individual donors. So in a single manufacturing batch of T cells from individual donor, we will have virus-specific T cells to direct it to 4 different viruses. That's what we do now. And how we do this, we actually designed a very sort of a clever strategy of very selectively using HLA-matched peptides, or these peptides mean small peptide fragments from these viruses, and made that as a pep mix, we call that. And these pep mix are then used to expand T cells from healthy volunteers. So we are collaborating with the Australian Bone Marrow Donor Registry. They recruit donors for us with the known HLA type, and every single donor goes through very rigorous testing for any advantageous virus or any other complications. Once the donor has passed the screen test, we take their peripheral blood mononuclear cells, we stimulate these with our pep mix, and these cells are then cultured over a period of 14 days. We do the QC testing for microbiological contamination or antigen specificity, and then store these as a cryogenic bank. On top of that, we have developed a AI-based algorithm which allows you very rapidly match these T cells appropriately with the patient. And how that works, this computer-based algorithm looks at these 6 different parameters. The first thing it will look at is whether the product has virus specificity, which you're looking for. Has it got the T cells which are specific for adenovirus, CMV, EBV, or BKV? How many number of HLA alleles are matched between the patient and the product that is in the bank? The third is the virus specificity of the matched alleles. So each of the allele has a HLA restriction. So it's not just the HLA allele matching, but the restriction of the allele, that there is a specificity to the virus in there. Then it also looks at how strong that T cell response is in the product. Is there an alloreactive response? And of course, we have to make sure there's a vial availability as well. So the program actually sets in the computer system, we feed in the HLA, high resolution HLA type of the patient, and immediately within 2 seconds, we get the results out with the possible options of the products that are in the bank. And those bank cells are actually put on what we call selection sheet. We then send that selection sheet to our clinical colleagues who have a choice to pick one of those, either 1 or 3 products, depending on the HLA matching and the virus reactivity with the product. And many of you who have sent those requests, you will see those selection sheet coming to you for your signature, and we use that routinely for all our stuff. And as a part of that process, we have now been actually taken this multivirus product in a phase 1 clinical trial, which is currently running at the Royal Adelaide Hospital, Prince Charles, and the PA Hospital in collaboration with our colleagues. And in this trial, we're actually using off-the-shelf allogeneic multivirus T cells for treatment of viral complications in SOT patients. To date, we have treated 11 patients. Don't get too worried about the slides. It's complicated. The reason is that the trial is going on, but I want to give a message across here is that each of these bar graphs or the dot line graphs are actually individual patients. And the red dotted lines on each of the graph are the points of the T cell infusion. And what you're seeing in not all, but many of those patients, you're seeing as soon as you put the T cell therapy, the virus load drops. But I want to make a point here is that in a lot of these cases, the patients often come to us quite late. And I'll request, if you're ever considering giving a T cell therapy, don't delay that request that comes to us. And those patients who do not respond, as is case here, they're not responding because they've already progressed so far that often they're not responsive to any other intervention, even not just the T cell therapy. We also have very interesting another trial currently running at the Queensland Children's Hospital and also other sites in Australia, where we're actually using multivirus specific T cells as a prophylactic therapy. And here what we are doing is that in this case, in these kids who are getting a haploidentical stem cell transplant, we collect the T cells from the donor before even the donor cells are mobilized. And these T cells, when they're collected from the donor, are then used for manufacturing the T cell therapy. Once the patient gets the stem cell transplant, and day 28 onwards, regardless of whether virus reactivation is not there or there, the patient starts getting T-cell infusions. And then they're followed after that. So this is the very unique first study, I assume, in the world where actually we'll be formally testing T-cell therapy as a first-line treatment before even you give any anti-prophylactic or a preemptive treatment. And we have to date treated 6 patients in this study. And you can see there are different immunodeficiencies, reason of haploidentical transplant, number of infusions that has been given. And you can see, I've seen that after the T-cell therapy, some of these patients have had viral reactivation, but those reactivation did not require any T-cell, any additional intervention from drug treatment. And here is one of the example, QACH03 patient, which did show a reactivation of adenovirus, but it didn't require any intervention because the T-cell immunity cooked in and actually control the viral infection. The one of the kid, which actually QC01, which did actually get problem for us, and it did not control CMV infection. We actually withdrew this patient from the trial. And actually, in that case, the patient was given a CMV-specific T-cell therapy, which was derived from one of the parent. And that patient received 9 infusions. And you can see this patient actually showed a complete resolution of CMV infection in this case as well. So along this trial, we are also one of the major providers of what we call off-the-shelf allogeneic therapies for critically ill patients. And many of these patients are not probably suitable for any of the standard clinical trials and often have drug resistance or a late end organ disease. And we have provided the T-cell therapies to 15 different clinical centers, not just in Australia, but also in New Zealand as well. And these therapies been given for viral complication or even for malignancies like NPC and other cases in patients. And this is just a summary of we're actually getting now a little bit burdened by these. So many requests are coming over the last just 5 years. We received well over 100 requests. And this is now increasing every day. Within just last 5 months, we now have 26 requests that have come to us for offering T-cell therapy. And you can see the breakdown of the majority are adult. Of course, we got a lot of pediatric patients, and many of these kids actually have adenoviral infection, quite severe one. And there are a number of underlying diseases for these cases that patients come to us, organ transplants, different types of transplant patients. And of course, the major request is coming from Victoria and also, of course, from Queensland here in this case. Very interesting, considering these patients have actually been through multiple lines of other treatment, to our pleasant surprise that the patients actually do well. Majority of them, like 60% of the patients seem to show clinical response to this sort of a compassionate use of T-cell therapy. And here are the 2 examples. One is the kid actually who's had an adenoviral infection. You can see it's been tried, and then patient gets a T-cell therapy, gets better. In this case, the patient has also been given Foscarnet and Maribavir, but also got a T-cell therapy, but shows a long-term stable immunity and able to control this viral infection. So I think what a message I want to give is that this technology is very useful and powerful only if the patients are given this sort of intervention early rather than late. And those patients in this case who do not show clinical response are those people who actually have very, very high viral load. And Brad has contributed to many of these patients here. And he can tell you that the non-responsiveness directly correlates how progressive the disease is. The later you come to us, the harder it becomes for us to sort of offer you any options for treatments for these patients. I'd like to sort of quickly close the talk and just these are the 6 people who I call them Tick Blue Crew, because they are the people who actually go into our clean rooms to do the manufacturing of cell therapies. For every single process, they spend days in those clean rooms where they're only allowed to come out once in a day, and they take up to 10 to 12 hours being in their rooms, and for very, very tough job. I would not even think of ever going in those rooms. And of course, this sort of work would not be possible if we didn't have a great clinical collaboration, and a lot of our colleagues at Royal Adelaide Hospital, Prince Charles, Dan Chambers, and many others. And of course, my own team, they have been absolutely amazing. Everybody contributes to this process of Michelle Natter, who you may have contacted many times. She's our clinical manager. She coordinates not just the trials, but also these SAS requests for T-cell therapies. Thank you. I'll stop there.
Thanks, Ravi. It's amazing stuff. We'll probably push on without questions, I think, again, but happening right here in Brisbane. Really world-beating research. Thank you.